Right. So we will start with questions on respiratory syncytial virus. One of the questions is, if RSV has been around before, why do the cases seem so much more severe this year?
Yeah, so this is a great question. I think as a pediatrician, we have seen RSV come and go every year, but over the past 2 years, the cases have been very few because of all the restrictions that we've had around physical distancing and masking, but now we're seeing an uptick. And it's not so much that the cases are severe, it's just that the peak is occurring much earlier and much higher than prior years. And so our hospitals are getting cases of RSV, cases of influenza now, and cases of COVID all at the same time. And so it's leading to a lot of hospitals being at capacity. And also because of staffing shortages, we're also seeing challenges with bed capacity. But thus far, we don't have great evidence demonstrating that the virus is causing more severe disease per se.
That's a relief.
Yeah, and the other part of it is, we have several generations of children who in the past would have been exposed to RSV. So most kids get infected with RSV before age 2. But over the past 2 years, since we haven't had RSV, we have all of these ages of children who haven't been exposed and are now getting sick. So some of the cases are in children who are a little bit older and otherwise would have gotten it previously.
That makes sense. So a lot of the protective measures that we had in place before led to fewer cases in the past couple of years, and now we're just seeing more people being exposed now.
Exactly, and earlier cases.
Okay.
In this season.
When it comes to RSV, because you mentioned, there's COVID and the flu happening at the same time, what are symptoms that parents should look for when it comes to RSV? And there was this graphic that was in JAMA. I don't know if
it's a great graphic. So it is more severe. The graphic's 100% right. It's more severe in younger children, especially kids under 1 year of age, and especially young infants. Kids who are at higher risk are kids who have chronic lung disease or chronic heart disease. So maybe your premature infant might be at higher risk if they're extremely premature. It is really hard to tell RSV from flu from COVID. It can typically start with just some sniffles and a runny nose, and then can progress to what's called bronchiolitis, which is sort of like an asthma type reaction in the lower airways. And these kids can get really sick and struggle to breathe and require oxygen in the hospital, or, in some extreme cases require what's called positive pressure ventilation, like a CPAP or a BiPAP. And in even more rare instances require intubation, mechanical ventilation.
Okay. And what would you say is the point where parents should contact their physician or go beyond just trying to treat their child at home?
Yeah, so I think there are a few reasons to contact your pediatrician. So one is if you have a child with a chronic medical condition, that might be an example of a reason to contact your pediatrician earlier rather than later. Otherwise, there are certain things we look for clinically, including things like retraction. So if you see the lung or the ribs kind of moving very quickly in and out, and patients sort of struggling to breathe, that would be another reason to bring your child to the doctor sooner rather than later. If they're not having wet diapers and appearing dehydrated or sleepy, sometimes babies can get tired because they're breathing so hard and so fast. those are all reasons to recommend bringing the child to see the doctor. Fortunately, most cases of RSV don't get hospitalized, but it is important to educate families about what to look for.
Great. This is helpful. And there were some questions about the new RSV vaccine that was in the news. How well does it work? Who should take it when it's ready? What should people know about it?
Yeah, it's a great question. So the RSV vaccine, unfortunately, it's not for babies directly. So there are two vaccines. There's that are really close to becoming available in phase 3 trials. There are other vaccines also that are being studied, but the two that have been mostly in the news are one that is given to pregnant women when they're pregnant, and it what it does is it stimulates the mother to produce antibodies that then are passed to the child, so that when the infant is born, they get protection from mom. And this is really key, because if we just gave the babies the vaccine when they were born, then they might not have sufficient time to develop an immune response to the virus before exposure. So this way they get mom's antibodies and then can be protected through the RSV season. And that was pretty promising. And then there's another vaccine that's being given to people who are over 65. And maybe Dr. Ramers has some comments about that if he's familiar with it, but there are increased rates of hospitalization in individuals who are over 65. And this vaccine also proved to have some efficacy in this age group. So these are really great news for those of us who've been doing this for decades, fighting RSV, and without really having any proven treatment or any vaccines. So this is really helpful.
Yes, that is definitely great news. Thanks for the update. Moving on to, are there any other RSV related questions in the audience?
I'll just add, I am not aware that these are going to be ready for this season yet. So it's great news and we're all excited about it, but this will be for next year at the earliest.
Right, exactly.
I have a question
for it.
as a parent. I think the question of whether you should get your child tested for these viruses. I think COVID, we're very used to the idea of testing. And I think RSV is always one of those things we don't know to get tested.
So I think there's a few reasons that you might want to get tested. So one question is, does your child have RSV or flu? And if your child is higher risk, it's very important to answer that question. So if your child has chronic lung disease or chronic heart disease or might be immunocompromised, because if they do have flu, they could get treatment for flu. So we do have oral options that can be prescribed by the pediatrician to treat flu. And then for RSV, if you know it's RSV, you might also be a little bit more cautious in terms of, watching for that bronchiolitis and watching for the lower respiratory tract disease. But if your child's otherwise healthy and they just have a runny nose and don't have a high fever or whatnot, you don't necessarily need to rush to get them tested.
Thank you. And I see a question in the chat. What are the preventive measures against RSV if different than for COVID that we can transmit to parents of young children?
Yeah, I guess the other good news is that it's the same measures that we've done for COVID. So it's really, masking. One thing about RSV that's a little bit different from COVID, it does appear to be a little bit more spread through contact transmission, meaning like if you have kids who are sharing the same toys, there's maybe a little bit more potential for spread through shared toys if the kid puts the toy in their mouth. But really, it's the same things. Wearing a mask, staying home when you're sick to not spread the virus to others, and then things like, washing your hands after you blow your nose or cough, etc.
Great. Any other questions related to RSV? And if there's more later, we can always add that, come back to it. The next question is related to COVID vaccines. There's a question of, is the 5th vaccine out yet? And I think it's related to, I think a lot of the messaging has gone out in numbering the doses. So the question is related to, is the 5th dose appropriate, or, you know?
Yeah, I can start on that one. So the answer is yes. We actually have 2 vaccines that are newly given licensing from the FDA, from Moderna and from Pfizer. But it's important to realize these are slightly different than the vaccines we've been using up till now. And the idea is similar to what we do with flu every year, which is to design the vaccine a little bit differently based on what is circulating. So both Moderna and Pfizer essentially changed their vaccine just a little bit. And this was on guidance from the FDA that actually asked them to do that. And the material they put in the vaccine was a little bit more targeted towards the Omicron variant, specifically BA1 and then BA4 and 5, which at the time were the variants that were circulating. So the hope was that by changing the vaccine a little bit, or changing the booster, that there would be a little bit better protection against those variants that are circulating. And I think there's a question later in the list here about, I heard that it wasn't as effective. Well, it's at least as effective as the original vaccine at giving protection. And there have been some studies saying it's better. So the data is a little bit mixed, but the idea that you can get the booster and get a little bit more specific protection against these Omicron variants looks like it's probably true. The studies that we see first are always looking just only at antibody levels, and that's only part of the picture. So I think that the new boosters actually do provide a slightly enhanced protection against the new variants that are circulating. So the answer is yes. I believe they've been out and available since around September, but it was a little bit later that the approvals got down to the younger kids. So I believe that the Pfizer version of this is approved down to age 5, and the Moderna is down to age 6, and that did not happen until mid-October. But they should be available where you normally get your vaccines.
Great. The next question actually relates to the monkeypox vaccine and asks, are we recommending the monkeypox vaccine now?
So the monkeypox vaccine, we're generally talking about a vaccine which is called Jynneos. It's Jynneos. And this is a vaccine that was originally developed for smallpox, but it also protects against monkeypox. And it is recommended, but only for certain groups that are at highest risk. Monkeypox is an infection that has predominantly affected men who have sex with men, but it doesn't really discriminate. It can infect anybody. That is just the most affected group that we have seen. And so the recommendations of using this vaccine have really been targeted towards those individuals. They've been loosened and generalized a little bit in the most recent recommendations from CDC that really says that the vaccine is available for anybody at higher potential exposure for monkeypox virus. So this has actually, originally the supply of this vaccine was very limited. And so it was being prioritized for people with HIV, for example, and sexually active gay men, or people that had a known sexual exposure recently, or had been to an event where somebody was known to have monkeypox. The supply is now much better. And so the criteria have loosened somewhat. So we have interpreted that anybody that is at risk of monkeypox to include healthcare providers who may come in physical contact with patients who are positive for monkeypox. This is a virus that is not nearly as contagious as other things like COVID or RSV. So you literally have to have skin-to-skin touch in order for this to be transmitted. So for example, someone that just happens to work near a healthcare facility, if they're not having skin-to-skin contact, they're really not at risk for monkeypox and probably would not need a vaccine. But healthcare providers, nurses, medical assistants who may be touching patients, taking vital signs, the providers that would be literally collecting the samples are the ones that really should be vaccinated. For the general public, not really necessary in most cases. And actually, we're seeing the monkeypox outbreak in general slowing down quite a bit. And this is one of those public health successes where as soon as public health kicks in and does its job, it's the outbreak that you didn't hear about that public health really takes care of. And I think watching monkeypox, there was a lot of fear that this was going to get out into the general population. And I think because of really good, strong public health messaging, the CDC and the White House doing a great job getting the word out to affected populations, and then very aggressive vaccine campaigns, we have largely contained monkeypox. I don't think it's going to go away completely, but it's becoming less and less common. And I can tell you in San Diego, we have had only between 0 and 5 cases reported per week in the last 4 to 5 weeks.
That's great news. I mean, public health definitely needs a win right now, so that's great to hear.
If I could just add one thing about the healthcare transmission, just that since many of you are community health workers, just to be aware that transmission among people working in healthcare is very, very low. There have been very few reported cases of people getting infected through healthcare. Most of those cases were individuals who, for example, had a needle stick or something like that, or were, they were not wearing the appropriate personal protective equipment. So if you wear gloves, for example, when, just as Dr. Ramers described, when touching somebody who has monkeypox, you're not going to get monkeypox. Just
yeah, the needle stick transmission case is kind of famous because it made it into a journal article, but that was literally a needle that was used to scrape a monkeypox lesion that a poor doctor in France stuck themselves with, and they developed a tiny little monkeypox lesion. So it is possible, but much more difficult to transmit than these other viruses we're talking about.
I believe Myra has a question.
Go ahead, Myra.
Oh, hi. Thank you. The question is regarding to the monkeypox. So yesterday I received an email from the CDC Foundation, and they are opening this opportunity for it's like a grant, a small grant. It's only for 3 months, starting next year, regarding to increasing in supporting the vaccination with the monkeypox vaccination. So what I'm hearing right now with Dr. Christian and Dr. Annabelle is regarding to it's not open to everybody. It's just for the immunocompromised people or gay people. So how the CDC is going to move forward with the monkeypox? Because honestly, for me, it's a little bit confused when I'm hearing here, when I'm hearing other ways, the CDC is saying something, the state, it's so confused. So I don't know if my question makes sense.
Myra, it's confusing to me as well, but I think that the monkeypox outbreak slowed down a lot earlier than many people thought. Mm-hmm. So our clinic, for example, we have been designated as a treatment center, and it wasn't until only maybe 2 weeks ago that all of the paperwork got set up. Oh, wow. And we have our doors open, and there's hardly any patients anymore. I still think that getting vaccinated for monkeypox, if you are at risk, is a good idea because it has not gone away. And I will say there was vaccine hesitancy. We now have dealt with vaccine hesitancy across the board. And there were many populations, particularly minority populations, Latinos and African Americans, that had relatively low monkeypox vaccination rates. So I think that's why CDC is continuing those efforts, and I think they are still important. In fact, my organization, we put together a mobile van, and it's out in the gay neighborhood in San Diego tonight. And actually, they said they were very busy. And it's just amazing. We've been trying to get people to come in for this for a month now, and there's still many people who have not received their vaccine. So there still needs to be a little bit more of a push. And this is to make sure that it does not come back again. I think we're just very lucky that things have been lower than we expected. But I do believe that continuing the vaccination campaign, particularly for minority communities, is still very important.
Okay, thank you. Appreciate that.
Thank you so much for your question, Myra. And please, everyone else, if you have any other questions, raise your hand, put in the chat, let us know. This is open. We have some preset questions that were submitted early, but the floor is open. Any additional questions about monkeypox?
I want to just make a comment, which is that there have only been a few deaths from monkeypox, so it definitely has killed far fewer people than COVID, but it is a miserable disease. We have treated maybe 30 patients with it. The isolation is really long. It tends to be 3 to 4 weeks for most people before their lesions are completely healed. It is very, very painful disease. I don't think we fully understand why that is, but these patients have awful pain, and many of the lesions are in very sensitive areas like the mouth and the genitals and the rectal area. So it's not killing people, but I would not wish this on my worst enemy. It's a very awful disease to suffer from.
That's a good point. It's so the next question is actually back to COVID vaccines. So if the COVID vaccines are meant to give you peak antibodies 2 weeks after you get it, should I time my vaccine for 2 weeks before I travel for the holidays to see family?
I have a very simple answer for this, which is you need to get it now. You do not want to wait too long. And we are just now starting to see COVID numbers go back up again. And it's a great idea to combine it with your flu vaccine. We've most commonly given one flu vaccine in one arm and one COVID vaccine in the other arm, just because it's a great time to get people protected against both. And let me address, I saw Myra make a little gesture there. We give, and Annabelle can speak to this as well, we give multiple vaccines at the same time very frequently in pediatrics, and people that don't understand immunology say, oh my gosh, it's going to stress my child out, it's going to be overwhelming. And when you study microbiology, you have a totally different understanding of the world. For example, you have something like 200 different species of bacteria in your gut at all times, and each of those bacteria make maybe 100,000 different proteins at all times that your immune system is interacting with millions of different pieces of bacteria and viruses all at once. So to give 2 vaccines at once is nothing. It is not a big deal. Our immune systems can handle it. In fact, by walking through your office or your house or your room, you are encountering hundreds of viruses every single day of your life. So to give 2 vaccines at once is not really a big problem. And I'll tell you, from our clinic, patients don't really report any increased severity of side effects from vaccines. And it saves a second trip to the doctor. So getting those 2 at once is a great idea. We have holidays coming up, and the peak antibody level, yes, most studies have shown 2 weeks, but then it'll persist for sort of 3 to 4 months. And so you want to be covered really through not only Thanksgiving, but Christmas and New Year's or whatever other holiday you celebrate, Hanukkah or Kwanzaa. And so now is the right time. I saw a question, Mayra, did you want to comment?
Yeah, and the reason why I react this way is because I personally got the flu shot like 3 years ago, and I was so sick for almost 2 months. It was terrible. I was like, I don't know, my side effects, it was really bad. I don't know if that is normal or my immune system is so weak. But yeah, it was like a wow, with the COVID and the flu shot at the same time, was like, oh Lord, you might have an extra space for me in your clinic.
Yeah, I'll say a little more about that. I mean, I can't deny that some people have reactions to the vaccines. It's kind of, when you understand what vaccines are, it makes a lot of sense. Vaccines are giving your immune system a dress rehearsal. It's a drill. And if you're going to send an army to war. The immune systems are really armies that are our defense, that are fighting against these invaders. You don't want your army to never practice. You want them to drill, and you want them to drill hard. And so that's what a vaccine is it's practice. It's a practice run against a bacteria or a virus so that you're ready when the real thing comes. Now, some people have bad reactions and they say, well, I'm not getting any vaccines ever again. And I would say that's not a great strategy because people react differently to every different vaccine. And so I would encourage people to continue to get them. And then also we often, this is the same thing I was saying about public health earlier, some of these diseases we don't really see much anymore. And I doubt that many of you have seen a person die of tetanus, for example. I have seen a person die of tetanus, and it is one of the most terrible things I have ever seen in my life when I was working in Africa. And yet this is totally out of mind. And I bet maybe Annabelle has seen somebody with measles. We don't really see that much anymore because the vaccines are so effective. And people just forget about that, and we get a little bit spoiled because the vaccines have worked so well. But we shouldn't forget how awful these diseases are. You can show you 10 to 15 different graphs, starting with terrible high levels of pediatric mortality and kids getting really sick. And in almost every case, the levels go down so much when the vaccines are widely accepted. The latest one I would say is cervical cancer in girls and boys. And other countries like Australia that have way higher vaccination rates like us, guess what? Their cervical cancer is going away almost completely. And yet we still have some of it because the vaccination rates are lower. Vaccines sometimes do cause some adverse reactions. They are tested so extensively that they will never even make it to approval unless those adverse reactions are so low, very, very low, on the order of 1 in 10,000 people or something like that. And yet their benefits are so great.
And the other thing I'll add about like the flu and the COVID vaccine, initially I remember back in, I guess it would have been 2021 when they first came out, there was some uncertainty. Can it be given at the same time? Do we need to wait? But there's actually data showing that you can give them at the same time and that patients actually have the same antibody level too. So that's another very reassuring thing, I think, for people who don't want to have a very sore arm. I think we talked about this the last time I was on. I mean, you give it maybe in 2 different arms, or, maybe one person just wants to have one sore arm. So I think you can also encourage people to have some decision making in the process as well. But a captive audience is much better than trying to delay things, because as we all know, we get busy and it's hard to make 2 appointments. So I think really encouraging people to get them at the same time is best.
I see a question in the chat from Claudia about what is a recommended time after COVID infection to get the updated COVID vaccine?
Yeah, I see that's question 9 also. So a couple different answers here. The first is there's not really any restriction on a minimum time, but if you have a choice, there is some evidence that if you wait 2 months after your most recent vaccine or 3 months after your most recent COVID infection, you'll get a little bit of a better response from the vaccine. So if somebody's trying to time it, again, I wouldn't put too much concern into the timing because we're starting to get into the busy season. But if someone has just recovered from COVID, there's a chance that they wouldn't respond as well to that vaccine, meaning their protection would be a little bit lower. That's pretty weak evidence, but it is out there. So if someone has the luxury to wait, that's the ideal time to get it.
Thank you. Claudia, did that answer your question? I realize I can't see people, so thumbs up, perfect. The next question, if our families have been vaccinated with the original vaccine, is it okay to gather without getting the bivalent booster?
I feel like that's kind of a trick question. I'm going to answer with, everyone should be getting that bivalent booster because it probably is going to give you additional protection. But we're in a little bit of a different time than we were last year. And what I mean by that is almost everybody has had at least a little bit of vaccine or has already had COVID. So the population at risk and the risk of somebody dying of COVID has gotten lower. We can be very proud of that because of our vaccines, and we have really good treatments now that are available for people that have COVID. I mean, I can remember back in the very beginning, my colleagues were terrified to go to work because we didn't know how you got COVID. We didn't have any treatments. We didn't have any vaccines, and it is a totally different time now. So the risk for your average person who's relatively healthy is really quite low of dying of COVID. You certainly still have a risk of some complications like long COVID, but the population that we are most concerned about has changed a little bit and shifted to those that are most vulnerable. So my question back to the person who asked this question is, who is in your family? And if you have somebody who is in their 70s or 80s, or who has just had cancer chemotherapy, or who takes medicines for a skin condition or a GI condition or arthritis that make their immune system weaker, then you should be very concerned about those people. Those are the people that we're seeing in clinics and in hospitals now. And those more and more are the people that are still dying of COVID. Okay, so we have learned a lot about how to prevent COVID. We know that the ventilation of the air is important. We know that masking really works very well, especially if you're indoors. We know that if you have symptoms, you really should take a test and isolate if you're positive. We know the vaccines work really, really well, especially at preventing the worst complications. And we know that there are fantastic treatments for people that have risk factors. So we have all of these things to work with, and we shouldn't forget any of them just because everybody's getting tired of COVID. But I really want people to understand that concept of the most you should basically design your family gathering to take care of the most vulnerable person in your family. It's just not fair to bring together 10 people who are low risk, all of them, except for Abuelita, who is 80 years old and is on chemotherapy and is the most vulnerable and could catch COVID, because that's the one I would be most concerned about.
Thank you. Yeah, it does feel like a trick question, but I think it's kind of the byproduct of the mixed messaging that's happening out in public right now. And the next question you kind of touched on earlier about the effectiveness of the bivalent boosters. You were saying it's kind of the evidence is a little bit mixed right now, but you still recommend the boosters.
Yeah.
And the next one is sort of related to something you, I think both of you mentioned before. If someone didn't have many side effects with their vaccine, should they be worried?
I want to hear Annabelle's thoughts on this. I've seen one paper that tried to look at this where they tried to see if the side effects you got correlated with the protection, and there really wasn't much correlation at all. So you might say, whoa, I really got side effects with that one. I must have really gotten a big boost, but it actually doesn't work that way from what I can tell.
Yeah, I've seen some mixed literature, some reports that if you have more side effects, then you have more antibody protection. But as somebody who has had zero side effects from any of the vaccines, I'd rather refer to your papers, Christian, because it has kept me protected. But, you know, with any of these articles, papers, et cetera, you know, you're not going to change your behavior either way. So if you had a lot of reactions after the vaccine, I wouldn't encourage you to do anything reckless. And if you had no reactions from the vaccine, you should remain protected, but I wouldn't spend a lot of time, you know, having additional worries about, you know, should I do anything crazy to protect myself. So I think the bottom line is, you know, getting vaccinated, most people get an adequate immune response to protect themselves. And getting vaccinated is the number one thing you can do to protect yourself against COVID.
That's a great recommendation. Okay, I know we've talked a lot about vaccines. Another topic on people's minds is long COVID, which, you know, we hear different things in the news. So one of the questions is, will getting the new bivalent vaccine be helpful for people with long COVID symptoms?
So this is a really complicated area, and unfortunately we don't have as much of an understanding as I would like. This has been an area, it's almost a brand new disease, although it's not quite a brand new disease, because there actually are other examples of fatiguing illnesses that happen after infections. And for a long time, many people, even within inside the medical community, just sort of didn't want to pay attention to these chronic fatigue syndromes. But it turns out it's a real thing, that after getting chickenpox or mono or any number of other infections, people can develop chronic fatigue syndrome. It's not really well understood what's actually going on here, but we're starting to get some clues with COVID. And there's a couple of different theories right now, and a lot of labs and America's best scientists are working on this. But a couple of the theories are that COVID damages your blood vessels so much that you have a very high risk of having clots, microclots they call them, all over your body. Long COVID can manifest in so many different ways that it is just confusing to those of us that are used to seeing a specific part of the body affected. So people with long COVID can have chronic lung problems where they get short of breath. They can have brain fog. They can have kidney issues. They can have really hard to understand skin rashes. They can have GI symptoms with diarrhea, nausea, and vomiting. And they can have cardiac symptoms or heart symptoms where their heart rate goes crazy. It doesn't make any sense. How can COVID possibly spur all of these different problems? Well, the one thing all of those organ systems have in common is blood supply. They all need blood flow. And we're starting to learn that COVID wreaks havoc on the endothelium, and that's the lining of all of our blood vessels. So the blood vessels that go to the brain and the blood vessels that go to the kidneys and to the gut and to the skin are all equally affected. And all of those blood vessels may be really, really messed up by having COVID and causing blood clots to happen, and therefore give the symptoms that keep on persisting. There's another theory that's somewhat related, which is that maybe the virus that causes COVID can persist in the body longer than we think. So there have been some studies, some autopsy studies, where they look at people that died of COVID, and they're actually finding the virus in many different places that we didn't expect, like in the GI tract and other places. So that's kind of my basic part about long COVID and what it is. The vaccine, basically anything that will prevent you from getting COVID is going to help reduce your chances of having long COVID, because of course you need to have COVID first to develop long COVID. And it does look like there is some protective effect. It's not perfect, but there is some protective effect of getting any vaccine against COVID that would protect you from getting long COVID. And there's now some new studies coming out saying that people that have had COVID repeatedly, every additional COVID episode that they have adds another couple percentage points of risk of developing long COVID. We have a project that uses a lot of patient information or patient advocates that have long COVID and that are suffering from this. And people that have long COVID are terrified of getting COVID again, because those that have gotten COVID that leads to long COVID and then get COVID again, it makes their long COVID that much worse. And so that community is very much in favor of anything you can possibly do to prevent an exacerbation or worsening. And I would say the bivalent vaccine is a great way to try to prevent that.
Thank you. That's a good argument for getting the bivalent vaccine for sure. On a related note, who is at most risk for getting long COVID, and are there any treatments that we know of? I mean, I know there's a lot of things being tried for long COVID patients, but are there any treatments that are more definite now or most helpful for long COVID patients?
So I can start. So the most at risk of getting long COVID. So there is a correlation with how sick you were. So there's a little bit of a higher incidence of long COVID in those that were hospitalized with their COVID. However, there have been so many more people that have had mild to moderate COVID that actually most people with long COVID had really mild cases and didn't have to be hospitalized. So I hope that makes sense. It's a little confusing, but per person, your risk of getting long COVID is higher if you were hospitalized. But because there's so many more people, hundreds of millions of people that have had mild COVID, we see a lot of people with long COVID symptoms that had mild disease. It looks like the older you are, there's probably a higher risk of having long COVID. In very young people, school-age children and teenagers, it's probably more like a 1 to 5% risk of having long COVID, whereas some studies in older people, it's 10 to 30%. So higher risk in the older individuals. And then there seems to be some correlation with underlying disease. So people that have things like diabetes and hypertension and obesity have slightly higher risk of long COVID. There seems to be a slight female predominance. Don't really know exactly why that is, but immune systems behave a little bit differently in women than they do in men. We see other autoimmune diseases, for example, that are a little higher in women. And then finally, I would say unvaccinated people have a little bit of a higher risk than vaccinated people. And I think there's one more thing, which is Epstein-Barr virus, which is the monovirus. People that have reactivity of that particular virus look like they have a higher incidence of long COVID as well. And the last thing I'll say is people that never sought out any treatment for COVID may have a higher risk as well. There's a paper that is really hot in the news right now that showed that Paxlovid, this is a huge study from the VA hospital system where they took almost 10,000 patients, looked at them that got Paxlovid, and then 50,000 patients that didn't get treated. And getting Paxlovid was associated with about a 25% lower risk of long COVID, and then a 50% lower risk of having a non-COVID related cause of death within 3 months. So Paxlovid is probably not being used as much as it should be because it's getting some bad press. But this is the best tool that we have right now to treat COVID, first of all, and then also to treat people and try to avoid long COVID. In terms of treatments for long COVID itself, the answer is no. There is nothing that is FDA approved. There is a lot of research going on right now, including some really interesting protocols, one of which really gets to this idea that there might be microclots. So giving a regimen of 3 very potent blood thinners under a very controlled clinical trial, because when you give blood thinners, you increase the risk of bleeding. And it looked like that actually worked quite well to relieve some people's symptoms. We don't have anything that has enough evidence to make us want to recommend it to everybody. So what we try to train doctors in about long COVID is, number one, you believe your patients that are suffering these symptoms. Even if you can't show it on an X-ray or a blood test, these people are suffering a lot. And a lot of patients are becoming very public about this, saying that my doctor gaslighted me. And they have to go somewhere else and they're told, oh, it's all in your head, or they're told, oh, it's just depression or anxiety, or you should just try harder. I know that you're fatigued, you should just try harder. These are incredibly damaging things for healthcare providers to say. And you have, we think, between 5 and 10 million people in this country that have debilitating long COVID symptoms, and maybe 4 million of those that cannot even work anymore because of long COVID. So this is a real phenomenon. The US government and the National Institutes of Health are really starting to focus on this. There's an institute called Recover, where there's $1.2 billion of research that are trying to find answers for this. So I know that was a long answer, but hopefully describe kind of where we are with long COVID.
Thank you so much. And I know Dr. De St. Maurice added some information about long COVID in children and adolescents.
I think the only thing I would add too is just for kids, you might be getting questions from family members if their kids had COVID before. And I think sometimes it's hard to differentiate the mental health consequences of the pandemic and the shutdown and the isolation that children and adolescents have faced with long COVID. And it's important to realize, just as Dr. Raymer said, that, these children are experiencing often real, very debilitating symptoms, and sometimes need to get modifications at school. So that's, another consequence of long COVID. So if you do have family members that are coming to you and asking questions about long COVID, it is 100% real. And I provided that AP guidance. There's also some information on CDC as well about long COVID. So it's important to just recognize that it can be real.
Absolutely. And that's a great point, because for students who, in addition to not having clinicians believe them, if teachers need to understand, they may need modifications to participate in school. Any additional questions from anyone else about long COVID kids? While we wait, there's another one here about, are you more or less likely to get long COVID with these new variants?
I've only seen a couple of papers looking at this, and it doesn't seem to be too different from variant to variant. So, I mean, I think people think variants are very, very different from each other, but it's really still the same virus. It just has a very slightly different spike protein on the outside of it. So otherwise, the virus behaves very similar. Maybe they get a little bit more transmissible when those spike proteins change a little bit, but by and large, it's still the same COVID. So not too much of a difference.
Okay. And this was the previous monkeypox question. Moving to COVID prevention, the question is, if it's important to wear a mask around others, why do people pull them down to talk?
Can I answer this one?
Yes.
I think it's because people don't really understand how masks work. So when you, just to be direct, so when you're wearing a mask, it protects you from generating droplets that others can inhale and then become infected. So if you pull it down when you're talking, you're more likely to generate these types of droplets or aerosols, which are really small droplets, and then infect others. So, if you are around somebody who's doing that, it's okay to politely ask them to keep their mask on.
Good point. Yes.
I
I
want to
think
make
it's just, oh, go ahead.
Well, it's actually in response to the next question, so I can wait.
Oh, no, we can go to the next one. So from your perspective, what is the most important thing to keep in mind to stay healthy over the holidays?
I think we, I like Tana's comment there. I think that we've talked about vaccines. That's an important step. We've talked about masks. Masks really work. There was another paper that just came out showing that masks would have prevented thousands of infections in schools if schools had kept masks on, the policies on a little bit more. They work. There's just no denying it. I don't feel like we need to wear masks forever. I mean, I'm in a room by myself and I don't need one. People that are outside by themselves really don't need them either. But anytime you're getting into an indoor place with lots of other people, you really should wear one, and you should wear a high quality one. And there was maybe a shortage at the very, very beginning, but there should be good N95 masks that fit your face well, that are pretty easy to get for most people. And the number one place where people absolutely need to wear it is when they're traveling. If you think about it, it's all a probability game here. So, there's going to be, in a group of 100 people, 1 to maybe 10 to 15 that have COVID or that have flu or that have RSV. And we've learned from COVID that sometimes they're not even sick yet. They could be pre-symptomatic and actually still spreading the virus. So, I don't have 100 people in my house. I have 4 people in my house. That risk is really low. The probability is small. If you think about an airport that takes, I don't know, San Diego Airport, there's a flight that takes off every 7 or 8 minutes. And each of those flights has 100 people on it. You are moving thousands of people into the same space, and your risk of being exposed is 10 to 100 times. any other place you would be. And I see patients over and over and over again that say, oh my gosh, I was so careful all through the pandemic, and then I went on a trip. And they're just exposed to thousands, literally thousands of people all sharing the same air. And if you've been in an airport recently, only 5–10% of people are wearing masks. So all that air is getting out to everybody. That is the one thing I would say is people are coming from all over the country. And let's say you have a family of 20 people that are getting together and they came from 20 different cities in the US. That means 200,000 exposures or something like that. The chances of people getting together, bringing COVID into their family is very much higher. And remember what I said before, you should be behaving the best way you can for your abuelita that is the most vulnerable among you. And if you don't think that's important, I feel like Tony Fauci explaining to Congress, I can't make you care about other people, but you really should. So that's what I have to say about traveling. Other just tips and tricks is that if you really should make a plan about what to do, and part of that involves having test kits with you. So there should be those quick rapid COVID tests. A lot of the community health centers have had them given to them for free. So we're sending a lot of patients home with it. That's a good thing to have with you. Get some good high quality masks if you're traveling around. And then just if it's warm enough where you are, still try to spend a lot of time outside because we know that risk is lower.
Those are definitely good tips. I think one of the challenges now is the funding for some of these resources have been drying up. But I know, at least for LA County, they're trying to send out monthly supplies to any community organizations who need them. I imagine other counties are hopefully making the same effort to make sure that there's still a steady supply of free testing, free masks as needed. Oh, this question did get answered. Why do some people test positive again after taking Paxlovid?
Good question. There was a study that Scripps Research actually just published, and it was looking at rebound. It should not be called Paxlovid rebound. It should be called COVID rebound. And we've known since the very, very beginning that COVID goes in a biphasic kind of way. So you have symptoms in the beginning where there's a lot of virus around. Typically, people feel a little bit better, and then some people feel a little worse actually in the second week. Paxlovid might sort of either accentuate that or it just maybe doesn't cover it the whole time. But it looked like in this trial that I think 15% of people or so that took Paxlovid had a rebound in symptoms. And then 9% of people that didn't take Paxlovid had a rebound. So it happens whether or not you take Paxlovid. And unfortunately, this is what I mean by the bad press that Paxlovid has been getting. People say, oh, I don't want to take Paxlovid because I might get rebound. What they don't know is that it might be Paxlovid that saves their life. So I think rebound has been a minor issue. We've treated 7,000 people and have not seen a single case of rebound that was serious at all. Maybe in a very, very, very vulnerable person, there has been one, but it's not really common at all. Sometimes the rebound makes people actually test positive again, and then they would have to isolate again another 5 days. So that's annoying, but again, it might happen whether or not you take Paxlovid. I don't really have a great answer for why. I don't think we fully understand that. I do know that there is a trial going on right now on, I saw it on clinicaltrials.gov, where what if you give another 5 days of Paxlovid, does that make it any different? So we don't know the answer to that yet. Tana, I want to answer your question in the chat too. It's a very simple one, and that is that we should be caring for each other more. This has been a problem in America that I think we've been heading down this road for like decades, where everybody's only looking out for themselves. And we need more community. We need more people taking care of each other. And that is an easy and simple message because it gets you through COVID. Why should you care about your abuelita that's 80 years old? Because you just should. Because we need more love. We need more community. Why should you care about the kid who's been isolated from school for 2 years? Because you should. We've been suffering, and we've had these the survival rate in the United States has been dropping for a couple of years because people are depressed, and there's higher suicide rates, and there's higher overdose rates, and there's higher alcohol use. and then 1 million people died of COVID. So what we really need is to care about each other more. That would be my 30-second PSA.
Thank you. And Dr. De St. Maurice, do you have a take-home message too?
I really like that. I think another one would be, there is hope, but we're not done yet. And that kind of goes along with the caring for other people more bit. We have all these great vaccines, all these great medications, all this knowledge, and we really need to continue using all of those tools that we have to make sure that we don't get to another bad place. So I think I really like the sense of optimism that Dr. Reimers mentioned.
Great. That's really great. And then I think that was all the questions. And then this was just an infographic to illustrate how we've kind of suddenly experienced the rising cases, like you mentioned in the very beginning, about how, masking and other interventions kind of kept cases low. And now we're experiencing the effects of people not masking and, being exposed to viruses all of a sudden. So let me stop sharing and see if there's any final questions from our group. We are so thankful for your time, Dr. Reimers, Dr. De St. Maurice. We know that your days are already busy in the clinic and with family and all these other obligations, even before this pandemic, but this pandemic's really, I think, pushed your schedules to the limit. So we appreciate how you've framed everything and how you've made the information much more easy to digest and to share with others in the community. We appreciate all of this. So thank you for making the time and sharing all of your knowledge. And thank you for all the community leaders that joined us tonight. I know you have long days as well, doing continued outreach and work with our communities to make sure everyone's protected. So we look forward, we'll compile the notes, figure out the recording and everything, and send out notes after this for those who couldn't join us tonight. But thank you, everyone. Stay safe, get your vaccines, wear your masks, protect each other, as our doctor said. Thank
Bye-bye,
you
everybody.
all.
Thank you.
Have a good night.
Thank you. Thank you, everyone. Have a good Thanksgiving.
Have a great night.
Thank you.
Bye.